Occupational English Test, Practice Test, Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Elizabeth. I'm Richard. I'm one of the nurses in this district, nursing. And the doctor has asked me to see you, so I guess you know that.
Yes, I do.
All right, yeah. So please take a seat.
Thank you.
Right, yeah. So, how can I help you?
Well, nurse, it's kind of a bit complicated. I've got this problem with my back.
All right.
And it hurts very bad.
All right, yeah. I've seen your case notes, and yes, I've seen that, yes. So, can you explain the situation you go through currently?
Yes, sure. I experienced this discomfort and a very stiff feeling in my back. It's been long.
All right.
And I used to use some pain relief ointment to relieve the symptoms, but off lately...
It's not working. All right, yeah. So, can you tell me when this started?
It was 1.5 years ago when the pain started.
All
I
right.
was prescribed with some painkillers back then.
All right, yes.
And after 12 months, there was no relief in the pain.
All right, so you have been taking the medicines consistently. All right, yeah, okay.
Well, I could not stand up.
Oh, okay. Right.
For which I was later hospitalized for, say, 2 days.
Okay.
And I underwent some blood tests along with the barium meal.
Oh, yeah. All right. Yeah, that's right.
Yeah. So later, after 6 months, I was diagnosed with a tumor in my back.
Oh, all right. Okay. Yeah.
For which I underwent a surgery. And a small part of my bone that was removed.
Okay.
That's what was told to me. And I was also told the tumor was spread to my liver and my lower back. And now that was very sad, and I was worried about it.
Right. So you said you were in terrible pain. Were you given some medicine for that?
Yes, I was. Pethidine 3 times per day and some alternative modalities for pain relief. I tried acupuncture for, say, 2 months, which I discontinued later.
Oh, so you felt that was not working?
Yeah, it was not.
Did you do something else for the pain?
Yes, I did, and I am still doing it. I smoke marijuana.
Marijuana?
Yeah, dope.
Okay. So that's not the ideal thing you should be doing.
I understand, but...
Right, yes. So what are your thoughts about what you are going through?
That's the main reason I've come to you.
Right, yeah.
I've been depressed for quite a long time, and I've been going through this rough phase. and I feel anxious about my illness. Even I get this weird thoughts of ending my life. I considered suicide.
I'm sorry to hear that.
Yes, yeah. But I just want to get this over.
Right, yes.
I need help.
Yeah, but Elizabeth, that's not the way out actually.
I know.
See, wanted to see you because, there are a couple of things that the doctor wanted me to discuss with you.
Okay.
And I would be arranging some counseling sessions for you.
That would be great.
Yes, so if that's fine with you, I can get that rolling in a few days' time.
Yes, of course.
And that's actually part of an ongoing modalities that the doctor wants for you.
Okay.
Right, and I can also try, some alternative modalities of pain relief.
Okay.
All right, and that would include many things, including acupuncture, acupressure, and yoga.
I haven't tried it yet.
Right.
Will it be?
Yes, it has helped many people who have, gone through things similar to what you go through.
All right.
So those things should be helpful, and that is, they don't have any side effects actually. And you should be seeing a specialist as well, if that's okay with you.
That would be fine.
Who would particularly help you through this phase of your life and help you to come out of what you are going through.
Yes.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Doctor. Good morning.
Good morning. May I know your problem?
Well, I'm having asthma and facing difficulty in walking even 10 steps. My weight is 344 pounds. I have high cholesterol and high blood pressure. I have joint pain, back pain, foot and ankle pain, and swelling on my leg and foot. I have sleep apnea and snoring. Moreover, I am a diabetic patient on medication. I also have hemorrhoids, Doctor. I am also pursuing surgical attempts for weight loss and to become active in my life again.
What's your age?
37, Doctor.
Okay. Do you drink or smoke?
I do smoke, and I have stopped drinking alcohol a year back.
Have you undergone any surgeries earlier?
I underwent orthopedic knee surgery, Doctor.
Can you brief me about your family history of diseases?
All my family members have obesity, heart disease, and diabetes, and negative for hypertension and stroke. But I am using Chantix to come off smoking completely.
Okay, tell me about your food habits.
I eat things like bacon, eggs, and cheese, cheeseburgers, fast food.
How many times do you eat in a day?
I eat 4 times a day, 7 in the morning, at noon, 9 p.m., and 2 a.m.
Well, the ideal weight for your age is 184 pounds, and you are weighing 344 pounds. That means 184 pounds in excess. What medications are you taking?
Diovan, Crestor, and Tricor.
Do you have any chest pains or any mild attacks?
No, Doctor.
Well, your cranial nerves 2 through 12 are intact. Neck is soft and supple. You have positive wheezing bilaterally. Heart rhythm is normal. Abdomen is soft. You have 1+ pitting edema. I have reviewed your complete test reports. This is a clear case of bariatrics, and you need to go for a laparoscopic Roux-en-Y gastric bypass. The complications include infection, bleeding, pulmonary embolism, deep venous thrombosis, leakage from the gastrojejunal, anastomosis, and possible bowel obstruction. Before we proceed for the surgery, you need to get reports on upper endoscopy, H. pylori testing, thyroid function tests, LFTs, glycosylated hemoglobin, and fasting blood sugar.
Okay, doctor. I would like to proceed with the surgery.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
Okay, your order sheet is in your chart. It's under the tab that's labeled Physician's Orders. You're going to check these orders against your paper MAR. There's 2 pages to your paper MAR, your routine medicines and your PRN medicines. So first check your patient's name, Sally Gunter, Sally Gunter. Okay, then check for the date of birth, 5/8/41, 5/8/41. The next thing you want to look at is allergies. Sally is allergic to penicillin. Your allergy is penicillin. And you want to go down and you want to verify every medicine that they have. So on the orders, it's potassium chloride, 40 milliequivalents, PO 3 times a day. Potassium chloride, oral, liquid, 40 milliequivalents, PO 3 times a day. K-Flex, 250 milligrams, PO every 6 hours. K-Flex, 250 milligrams, PO every 6 hours. Norvasc, 5 milligrams, PO twice a day. Norvasc, 5 milligrams, PO twice a day. Prilosec, 20 milligrams, PO daily. Prilosec, 20 milligrams, PO daily. When you're looking at your physician's order, make sure it has a date, a time, and a physician's signature. Sally Gunter also has a PRN order of clonidine, 0.1 milligram tablet every 6 hours, PRN for diastolic blood pressure greater than 90. Clonidine, 0.1 milligram tablet, PO every 6 hours, PRN for diastolic blood pressure greater than 90. Now all your routine meds and your PRN meds are checked against your physician's order sheet. The next thing you want to do is to look here. Number 1 is compare your order sheet to your MAR and then your initial once verified. So you would sign your initials that you verified these medicines.
Question 26. Now read the question.
Let's examine this. If I have a fearful thought that I could ultimately lose everything, then it's not going to move me forward. It's not going to help me think clearly. It's not going to help me, move forward and take the actions that I need to take. It can kind of limit me and make me feel like I don't want to do anything because I'm scared to do anything. But what I have found, and this is what I do all the time, is when I'm having a fearful thought, I know that I can't not think about something. Because the more you try to not think about something, the more you're just going to think about it. So you have to replace that thought. And what I replace that thought with is, how can I use this fearful thought or use this fearful event to make me a better person, a better nurse, and to learn from this experience? I'm happy to share this with you so that you can, hopefully learn from my mistakes. So what happened was I realized that I made the mistake, and not only had I made the mistake once, I had actually done it the first time I administered the medication as well. So I thought about it and I was like, okay, well, of course I have to do an incident report. With the mistake, I'm going to show her that I can, not only take care of the situation and have her trust me with her patients, but she can also see that I'm a very confident person and that this mistake won't happen again. So I went to her and I said, I told her the mistake, ultimately told her what happened, and, it was a mistake, and we examined it, and, she asked me a few questions, and it was an uncomfortable situation, but what I realized was that I came out of that as well as I possibly could have. Having the lack of confidence, you can replace that with, no matter what happens, I will build from this and I will learn from this and I will ultimately become a better person. So guys, it's all about replacing those fearful thoughts with thoughts that are going to serve you.
Question 27. Now read the question.
I was actually talking about culture-bound phenomena, and I had a professor of psychology say to me that there's no evidence that culture-bound or cultural illness exists. And I actually said to him, my response to him was that you're absolutely correct. And people were quite surprised when I said, you're absolutely correct in the world in which you live. So you actually can't necessarily blame someone if they've never actually been exposed to it before. So the important point is that if you actually don't have it in a framework that most people, and what I'm talking about is mainstream, can relate to, in that it's actually researched and it's written up in a scientific journal, then they're actually forced to relate to it, or at least open their mindset up to a different reality.
Question 28. Now read the question.
Hello, I'm Jan Machescu. I called this morning.
Yes, Mr. Machescu, your prescriptions are right here. They've been ready for an hour.
Good.
Now, take these pills 3 times a day. That's every 8 hours.
I usually take them at 7 in the morning, 3 in the afternoon, and 1 before I go to bed about 10 or 11 at night.
That's fine.
When do I take the other pill?
You can take these any time you feel a pain.
Well, it's almost lunchtime. Is it okay if I take one before lunch?
It's better if you wait until after lunch, after you've eaten.
Well, why is that?
The pills may upset your stomach if it's empty.
Oh, okay. I'll wait till after lunch. I'll take one about 1 o'clock this afternoon. Well, thanks very much for your help.
You're welcome.
Question 29. Now read the question.
Right, I'd like to tell you about all the patients on this ward, starting with bed 1. John Smith is a 45-year-old male who had a motorbike accident on his way home from work. He was admitted to the ED at 2300 hours on the 1st of August with a frontal lobe contusion.
Sorry, I don't know that word contusion. Could you please explain?
Sure, in this case it means a concussion. Thank you. He has breaks in his right arm and hand and has had surgery, including metal plates inserted into his arm. He also has deep grazes on his left knee and ankle and stitches in his right hip and shoulder.
Stitches in the right hip and shoulder?
Yes, that's right. All dressings have been changed this morning at 900 hours. He's on a self-administered morphine drip and he's also on an antibiotic drip. He has had injections to prevent blood clotting, and his pain is quite manageable with the medication he's on.
Question 30. Now read the question.
I worked for this man called Graham. That wasn't his real name. He started to hear voices. He had strong paranoid beliefs that people were talking about him. He had to come into hospital, and the main way of actually helping overcome that loneliness and isolation as a result of his experiences was to really enter his world, to develop a shared model, a shared understanding of how these experiences shaped his beliefs and how that made him feel both emotionally and how he reacted behaviourally by avoiding a whole range of situations. It makes me feel really good actually, and it gives me a tremendous source of satisfaction that actually by relating to somebody, by understanding somebody, that you can actually empower them and help them recover. Without the benefits of professional help, Graham would still be stuck at home. He would still be experiencing rather distressing voices.
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
As a physiotherapist of 22 years, I've been asked all sorts of questions, but the one I hear most often is, can physiotherapy help my condition? Physiotherapy assesses, diagnoses, treats, and prevents a wide range of health conditions and movement disorders. It helps reduce pain and repair damage while increasing mobility and improving quality of life. In some instances, it can be an effective replacement for surgical intervention. Obviously, not all conditions can be cured by physiotherapy alone, but help it can certainly do. So today, I'd like to focus on a condition that still creates controversy when mentioned alongside physiotherapy, and that is scoliosis. Can physiotherapy make an impact on someone suffering from this condition, in particular mild to moderate scoliosis? Let's find out. Scoliosis isn't always easy to treat, but understanding this condition and its related issues will help a physiotherapist determine the best possible options. A scoliotic spine has one or more curves to either side exceeding 10 degrees. It can resemble a C or an S shape. What makes it difficult to treat is that the majority of cases have no known cause. Two specific types are easier to deal with, however: structural scoliosis, which results from the development of the musculoskeletal system, and functional scoliosis, which occurs from muscle imbalances, leg length discrepancies, and inflammation of the tissues. These both have definite causes, allowing us to create an individualized and comprehensive treatment plan. Physiotherapy is but one part of the multidisciplinary network of healthcare professions employed in the treatment of scoliosis. A confirmed diagnosis comes firstly from a thorough physical examination for any abnormalities and asymmetry. If scoliosis is suspected, then an X-ray will be taken to confirm what's known as the patient's Cobb angle, or severity of the scoliosis. From here, physiotherapists work closely with doctors, including orthopedic spine specialists, in determining the best options going forward. I believe a good, multifaceted approach to this is ideally broken down into 4 distinct phases. The first of these, in my program, is pain relief. Although not all scoliosis sufferers will experience pain or even discomfort, many do, and for these patients, the provision of pain relief assists with compliance and also with corrective or prevention exercises. Physiotherapists have a variety of techniques for achieving this, such as the releasing of tight muscles through gentle massage, acupuncture, the use of supportive postural taping, and various electrotherapy modalities such as ultrasound. Phase 2 is a particularly important step for several reasons. It's for rectifying any imbalances through stretching and strengthening exercises. This often still includes taping techniques until strength and flexibility have increased. Physiotherapy here focuses on both sides of the spine as well as adjacent areas like the hip or shoulder, depending on what's impacting spinal alignment. The aim is to restore the range of motion of the spine, muscle length and strength, as well as endurance and core stability. This stage is paramount for allowing ongoing treatment in Phase 3 to occur. This is because it's there that the patient requires the strength and flexibility gained in Phase 2 in order to resume normal activities. These include sport and recreation, which is the objective most patients have in mind during the treatment process. It's where we aim to restore full function. This is where we, as physiotherapists, need to tailor rehabilitation to the specific patient so they can safely achieve their functional goals. This, of course, includes trained athletes who place great stress upon their bodies, so caution must be taken when giving advice, and strong encouragement is needed for keeping to realistic recovery times. The final phase is undoubtedly the most important in terms of full recovery, and this is the prevention of a recurrence. This relies heavily on the partnership between physiotherapist and patient. By this, I mean we identify the optimal exercises for the patient to continue, and it's then up to them to maintain these exercises throughout the course of their life. Here too, other professions may be utilised. For example, in a case of an unequal leg length, a podiatrist could address this with a heel rise, shoe rise, or built-up foot orthotic. What patients expect to achieve and what is achieved varies greatly. However, those with mild to moderate scoliosis who have a commitment to maintaining their newfound strength and flexibility can expect a full recovery, especially if diagnosed and treated early. Physiotherapy is a vital part of this recovery and prevention and should never be underestimated. So, the next time you're asked, can physiotherapy help my condition, I'd be inclined to give a firm nod and respond by saying, with your commitment, physiotherapy is invaluable.
Now look at Extract 2. Extract 2. Questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Hello, doctor. Can you explain how vulvovaginal candidiasis infection occurs, its symptoms, and its treatment?
Vulvovaginal candidiasis is a syndrome rather than an infection, and diagnosis of vulvovaginal candidiasis does not rely on clinical or laboratory criteria alone, but a combination of these two. Usually, vulvovaginal candidiasis is caused by C. albicans, but can occasionally be caused by other Candida sp or yeasts. Typical symptoms of vulvovaginal candidiasis include vaginal soreness, pruritus, dyspareunia, abnormal vaginal discharge, and external dysuria. However, none of these symptoms are specific for vulvovaginal candidiasis. About 75% of women will have at least one episode of vulvovaginal candidiasis, and 40 to 45% will have two or more episodes. Based on clinical presentation, microbiology, host factors, and response to therapy, vulvovaginal candidiasis can be classified as either uncomplicated or complicated. About 10 to 20% of women will have complicated vulvovaginal candidiasis, requiring special diagnostic and therapeutic considerations. Types of uncomplicated vulvovaginal candidiasis are sporadic or infrequent vulvovaginal candidiasis, mild to moderate vulvovaginal candidiasis, likely to be Candida albicans on immunocompromised women. Complicated vulvovaginal candidiasis are recurrent vulvovaginal candidiasis. Several vulvovaginal candidiasis, non-albicans candidiasis, women with diabetes, immunocompromising conditions, debilitation, or immunosuppressive therapy. By the presence of symptoms such as external dysuria and vulvar pruritus, pain, swelling, and redness, a diagnosis of Candida vaginitis is suggested clinically. Signs include fissures, vulvar edema, excoriations, and thick, curdy vaginal discharge. The diagnosis can be made in a woman with signs and symptoms of vaginitis when either a Gram stain or preparation of vaginal discharge demonstrates budding yeasts. Pseudo-hi-fi, hi-fi, or a culture or other test yields a positive result for a yeast species. Use of 10% KOH preparation in wet preparations improves the visualization of mycelium and yeast by disrupting cellular material that might obstruct the visuality of yeast or pseudo-hi-fi. Examination of a wet mount with KOH preparation should be performed for all patients with symptoms or signs of vulvovaginal candidiasis. For patients with negative wet mounts but existing symptoms or signs, vaginal cultures for candida should be considered. In case candida cultures cannot be performed, then an empiric treatment can be considered. Identifying candida by culture in the absence of signs or symptoms is not an indication for treatment, since approximately 20% of women harbor candida sp and other yeasts in the vagina. However, postcoital testing for yeast is not approved by Food and Drug Administration. Culture for yeast remains the gold standard for diagnosis. Vulvovaginal candidiasis can occur concomitantly with sexually transmitted diseases. Most healthy women with uncomplicated vulvovaginal candidiasis have no identifiable precipitating factors. Short-course topical formulations effectively treat uncomplicated vulvovaginal candidiasis. The topically applied azole drugs are highly effective than niacin. Treatment with azoles results in relief of symptoms and negative cultures in 90% of patients who complete therapy. Over-the-counter intravaginal agents clotrimazole, 1% cream, 5 grams intravaginally daily for 7 to 14 days, or clotrimazole, 2% cream, 5 grams intravaginally daily for 3 days, or miconazole, 2% cream, 5 grams intravaginally daily for 7 days, miconazole, 4% cream, 5 grams intravaginally daily for 3 days, or miconazole, 100 milligram vaginal suppository, 1 suppository daily for 7 days, or miconazole, 200 gram vaginal suppository, 1 suppository for 3 days, or miconazole, 1200 milligram vaginal suppository, 1 suppository for 1 day. Teoconazole, 6.5% ointment, 5 grams intravaginally in a single application. Prescription intravaginal agents, butoconazole, 2% cream, 5 grams intravaginally in a single application, or turconazole, 0.4% cream, 5 grams intravaginally daily for 7 days, or turconazole, 0.8% cream, 5 grams intravaginally daily for 3 days. Turconazole, 80 milligrams vaginal suppository, 1 suppository daily for 3 days. Oral agent fluconazole, 150 milligrams orally in a single dose. This is the end of Part C. You now have 2 minutes to check your answers. That is the end of this listening test.